My name is Dr. Emma Sokolova. I'm from Latvia, Riga Stradiņš University, representing Riga Stradiņš University and Riga Stradiņš Clinical University Hospital. And my topic is myocardial inotropic function while receiving antiarrhythmic first C-class medications. Is it worth worrying about? Well, we all know that atrial fibrillation is one of the most common arrhythmias among adults all over the world. And it leads to decreased quality of life, increases morbidity, mortality, and also decreases life expectancy. Nevertheless, changes of inotropic function of the myocardium that can be accessed non-invasively of both of the ventricles of the left and right ventricles in patients with this arrhythmia during the restoration of the sinus rhythm has not been practically studied before. We did this study as an open label, one-center prospective study with the patients with atrial fibrillation who received beta blockers, bisoprolol, 5 milligrams daily, amiodarone, propaphenone, or aethacizinum, so-called aethacizinum, that is also a first C class antiarrhythmic medication that is registered not in all of the European Union countries, but in most of them, for 6 months after cardioversion to the sinus rhythm. And we've also evaluated patient symptoms and safety. We took also brain natriuretic peptide level. We performed rest ECG, exercise stress tests, valorgometry. We've performed transthoracic echocardiography to complete blood count, clinical biochemistry, performed also Holter monitoring. As an inclusion criteria for us was an paroxysm of atrial fibrillation, not longer than for 48 hours, and patients have not received any arrhythmic drugs before. Exception was for amiodarone and beta blockers. As an exclusion criteria, there were a lot of them, all acute coronary syndromes or surgeries, major traumas during the last months, ischemic heart disease with decreased ejection fraction of the left ventricle, acute inflammatory diseases, heart rhythm disorders, chronic obstructive lung diseases, severe kidneys and hepatic pathologies, anemias, severe obesity, oncological disorders, or any other diseases associated with poor prognosis, thyroid gland diseases, diabetes, uncontrolled hypertension, pregnancy, or non-intolerance to any of antiarrhythmic medications or previous use of first C-class antiarrhythmic medications, and for sure excessive consumption of alcohol or non-poor compliance. At the baseline, we had 62 patients. During first 3 months, 3 excluded for the personal reasons, and for the last follow-up after 6 months, we've got only 57 patients because 2 were moving abroad and could not plan last follow-up visit. At the baseline, we had in per protocol group 63% of female genders, and the mean age was 62 years. 25 of them were smoking with pretty normal systolic and diastolic blood pressure, little elevated. And most of them performed some mild physical exercises during the week. And at the baseline, 20 of these patients, or 36%, received therapy with aethacizinum, 15 of them with propaphenone, and 15 with bisoprolol, and only 7 with amiodarone. No safety parameters changed significantly in per protocol group. None of them experienced any major adverse events in 6 months. No statistically significant changes also were observed in blood tests, ECG, or Holter perimeters. In our research, duration of atrial fibrillation was not predictive value of maintenance of sinus rhythm and follow-up. And between atrial fibrillation and sinus rhythm groups, echocardiographic data showed no significant changes. And also there were no significant changes found in early diastolic atrial myocardial velocity and strain. What is interesting is that recurrence rate of atrial fibrillation in the group of aethacizinum showed close to statistically significant superiority compared to the propaphenone. And there are also mentioned some echocardiographic characteristics of patients who maintain sinus rhythm and sinus rhythmations and atrial fibrillation patients. But as you see, we had only left atrium volumes that changed statistically significantly after successful cardioversion and 6 months lately. As a conclusion or discussion, I even would like to say that previously there was described negative impact of first C-class medications and of propaphenone of the left to the left ventricular ejection fraction, but still we had no data about efficacy of rhythm maintenance and safety of widely used aethacizinum. And this actually was the first attempt to study this myocardial response to first C-class medications during sinus rhythm restoration using non-invasive methods as echocardiography, continuous Holter monitoring, echocardiography. And all these investigations, they did not show any significant changes in both of the patient groups. And this can be most probably explained by cardiac cycle, because during the diastole of the ventricles, atria are emptying passively. As a result, left ventricle has a strong influence on function of atria during early diastole, and patients with higher atrial strain have better opportunity to maintain sinus rhythm. Antiarrhythmic medications of first C-class may be safe in patients with persistent form of atrial fibrillation and have no negative impact of inotropic function on myocardium. The most widely used medication in Latvian population is from first C-class is aethacizinum, and the observed efficacy provides a rationale for a larger double-blind control study with different antiarrhythmic medications in different daily dosage. Thank you for your attention.